We're going to start out with the first presentation being today for, I have a cardiac patient, one of those patients I hate taking care of for a non-cardiac surgery. When do you actually need to consult or have a cardiac anesthesiologist? And our first speaker is going to be Dr. Rhea Richardson. She's currently one of my colleagues at the Cleveland Clinic. And she did her training at Case Western for medical school. She did her residency and her cardiac anesthesia fellowship at Cleveland Clinic. And she's going to be coming up today to give this presentation that I just named. So Rhea, please come on up and let's give her a very warm welcome.
All right, good morning, everyone. And again, my name is Dr. Rhea Richardson, and I'm very happy to be here with you guys today. So the title of my presentation is Cardiac Patient for Non-Cardiac Surgery. When do you need a cardiac anesthesiologist? And I do not have any disclosures. And with this talk, I want to hit a couple key points. So I want to make sure that you guys understand what makes a cardiac anesthesiologist, like what differentiates our subspecialty from general anesthesia. Touch and talk about how to be able to identify high-risk cardiac patients in the non-cardiac OR setting. And then I'll wrap up with talking about perioperative challenges when managing some of these patients with significant cardiac pathologies, and how a cardiac anesthesiologist can help optimize care. So what exactly is a cardiothoracic anesthesiologist? So it's a anesthesiologist that's undergone cardiothoracic anesthesiology fellowship, which is a 12-month longitudinal experience where it's devoted to the preoperative, intraoperative, and postoperative care of adult patients undergoing cardiothoracic surgery and related invasive procedures. So it ends up being 12 months of just nosediving into cardiothoracic anesthesia, dealing with these sick patients, and really getting comfortable with managing complex cardiac pathologies, and also in becoming an expert in advanced level perioperative transesophageal echocardiography, or TE. So given the fact that there's been a rise in demand for specialized cardiac anesthesiology care, there's been a recent approval of ABA, adult cardiac anesthesiology examination, and this will just further certify us as experts in the imaging, diagnosis, physiology, pharmacology, and management of care of these adults with cardiac disease, which requires leading-edge techniques, interventions, and the latest treatment technology. So as we know, anesthesia is a team sport. We collaborate with different specialties all the time, but when can a cardiac anesthesiologist help? So in some situations, you may need expert opinion on perioperative management of these difficult cardiac pathologies. Cardiac anesthesiologists can also help with the placement and interpretation of invasive hemodynamic monitors, including difficult central venous access, pulmonary artery catheterization, and also, and most importantly, in the use of perioperative transesophageal echo. But the whole caveat to this talk is, depending on your own personal comfort level and skill set, you may not actually need us. So I'm just going to talk a little bit about some situations where our input may be of use. So to dive in a little bit, when can advanced monitoring be helpful? So in 2014, the American College of Cardiology, along with the American Heart Association, developed guidelines outlining perioperative cardiovascular evaluation and management of patients undergoing non-cardiac surgery. And in those guidelines, they did outline that emergency TE use is reasonable when determining the cause of persistent hemodynamic instability despite corrective measures. So that may be a good time to call in for a cardiac anesthesiologist just for their input. And also with advanced monitoring. So for example, you may consider a pulmonary artery catheter use in patients with pathologies that can significantly affect hemodynamics. So kind of taking that a step forward, when is a good time for transesophageal echo? So the American Society of Anesthesiologists, along with the Society of Cardiovascular Anesthesiologists, came up with some guidelines outlining when transesophageal echo could be useful, even in non-cardiac cases. So if there's known or suspected cardiac pathology that could cause significant intraoperative complications, in cases where there's unexplained persistent hypoxemia or hypotension, and also in cases where you anticipate life-threatening hypotension. So some of these big non-cardiac cases, this may be a good time for a transesophageal echo, and cardiac anesthesiologists can help in providing assistance in that department. So taking a step back, why does this all matter? We know that surgery is a physiologic stressor. We also know that major adverse cardiovascular events are a leading cause of perioperative morbidity and mortality after non-cardiac surgery. And going on in time, we know that there's an increased prevalence of heart disease patients. So our patients are ultimately getting sicker and sicker and presenting more often for these non-cardiac and sometimes routine procedures. These patients are high risk, and they're at increased risk for developing complications when compared to healthy adults. And to add on to that, emergency cases have a 2 to 5 times higher risk of these MACE events when compared to elective cases. So we have sicker patients that we ultimately want to get through surgery as easily as possible. And how do we do that? Sometimes we do need a little bit of consultation and assistance. And as anesthesiologists, it's our daily routine to know what we're dealing with. So ultimately, our goal is to stratify patients and understand their cardiovascular risk of mortality and morbidity. So we look at patients themselves. So high-risk patients would include those that have experienced recent myocardial infarction or unstable angina, decompensated heart failure, high-grade arrhythmias, significant valvular disease. And then we also have to look at the surgery itself. So high-risk surgeries include major emergency surgeries, major vascular surgeries, peripheral vascular surgeries, as well as anticipated prolonged procedures with large fluid shifts or blood loss. So there are a couple tools for risk stratification that we have handy. Of course, our history and physical is our best tool yet. You gather a history, you understand a patient's prior interventions, their current medications. You take a look at their symptoms and their related pathology, understand their functional capacity, and of course, undergo a physical exam because you can get a lot of data from that as well. There are some risk calculators that are available, like the Revised Cardiac Risk Index, which I heard a lot about during my general anesthesia training. It's used for stable patients undergoing non-urgent major non-cardiac surgery, and it helps identify patients that are at high risk for 30-day mortality, including death, myocardial infarction, or cardiac arrest. So if a patient has three or more of these predicting factors, they're deemed high risk, and they may be a candidate to just consult with a cardiac anesthesiologist to go over a plan and also think about how we're going to take care of this patient during the preoperative period, intraoperatively, but also what postoperative considerations we should think about. Another known risk calculator was done by the American College of Surgeons, and it's a surgical risk calculator. It's much more extensive. It uses 20 patient predictors and also looks at the planned procedure to calculate the risk of having multiple different outcomes, of which include cardiac outcomes, which are cardiac arrest or myocardial infarction. This calculator does take into account emergent procedures. So, for example, if you have a higher risk patient, again, this may be a good opportunity just to touch base with the cardiac anesthesiologist to see how you can optimize that patient's care. There are some limitations with these risk calculators. For example, the RCRI is for non-emergent procedures and doesn't take into consideration some cardiac pathologies, including aortic stenosis. And this American College of Surgeons one doesn't include aortic stenosis or cardiac artery disease as risk factors. So these are just some tools to use to help risk stratify patients. And for example, if you do have a higher risk patient, that may be a case that you may want to consult a cardiac anesthesiologist. So I wanted to go over a couple case scenarios, just an overview. In some situations where cardiac anesthesiology input may be of help. So the first case, we have an 89-year-old gentleman who presents to the emergency department following a mechanical fall. Imaging shows a hip fracture requiring orthopedic surgery. His history is notable for increased shortness of breath on exertion, and on exam, You hear a high-grade systolic murmur near his right upper sternal border. There's no cardiac imaging available, but you have a high suspicion that this patient has some degree of aortic stenosis. So, for example, this could really change your management of a case. For a case like this, under normal circumstances, you may want to just do a spinal and keep going. But you have to really consider how this potential cardiac pathology can influence your case progression. So in this situation, cardiothoracic anesthesiology can help with doing a quick grading of the severity of the cardiac pathology to help further guide management. So symptomatic stenotic lesions, we see this more and more in the non-cardiac operating rooms, and aortic stenosis is the leading or more frequently seen cardiac valve lesion in the United States. And what makes this severe stenotic patients really tricky to manage intraop and even perioperatively is that you have a fixed restrictive lesion along with a hypertrophied ventricle. So with that fixed lesion, you can have limited cardiac output, and which can severely impair resuscitative efforts. And you have that hypertrophied ventricle that causes diastolic dysfunction, which leads to a higher risk of type 2 myocardial infarction due to impaired coronary perfusion. You have an increased sensitivity to ischemia, and there's more of a reliance on the atrial kick for ventricular filling. Depending on where the disease is in terms of disease progression, you can have diastolic dysfunction, and if the patient has long-standing aortic stenosis, that can further complicate everything, leading to systolic dysfunction. So the biggest things that we need to think about with management is you want to strategize perioperative care to include optimizing loading conditions. These patients are preload dependent, so you want to avoid hypotension at all costs. You want to have a normal to high afterload, and you want to maintain, in order to maintain appropriate coronary perfusion, and you want to avoid tachycardia because that increases myocardial demand, decreases left ventricular filling, and as well as coronary perfusion time. So for these patients, you want to be very careful with optimizing these goals, and in order to do so, we typically will place a pre-induction arterial line so that you can monitor pressures accordingly, and put on defibrillation pads because chest compressions will be of limited use in these situations. So just talking to a cardiac anesthesiologist in these situations can help fine-tune your plan so that you minimize any of these complications. Another symptomatic stenotic lesion to worry about is mitral stenosis. So that does lead for an increased risk for acute pulmonary edema, and you want to avoid increased left atrial pressure and pulmonary wedge pressure. And for larger cases, you can also consider a post-induction pulmonary artery catheter in addition to the pre-induction arterial line and large bore peripheral IVs to gather more information to avoid that complication. For the next case, it's a 48-year-old female with a history of chronic, moderate to severe mitral regurgitation who's presenting for left breast lumpectomy. So another area that a cardiac anesthesiologist can provide guidance is when dealing with severe symptomatic regurgitant lesions. So generally, regurgitant lesions are much more well tolerated than stenotic lesions, but severe left-sided lesions can typically cause left ventricular volume overload. And ultimately, the goal is to maintain adequate fluid balance. But taking all of this into consideration, timing does matter. So chronic regurgitation versus acute has very significant implications. So in the chronic regurgitant lesion patient, you do have time for the heart to compensate. So you have compensatory dilation. Versus in the acute phase, you don't have that time. So you have a higher risk for acute pulmonary congestion complications leading to pulmonary edema. Of course, there is an increased morbidity and mortality in these patients. And ultimately, the goal is to promote forward cardiac output flow. So you want to maintain preload, avoid increased afterload, and maintain your higher normal heart rate. So ultimately, increased monitoring will help with managing these patients, most likely with an arterial line, and just discussing goals of care to minimize some of these complications. So the next patient is a 23-year-old male with known hypertrophic cardiomyopathy. He has no obstruction at rest and an ICD in place that presents for an XLAP due to concern of internal bleeding following a motor vehicle accident. He's hemodynamically stable at present. So another cardiac issue that you may run across is hypertrophic cardiomyopathy. And that's where the patient has a thickened ventricle with or without left ventricular obstruction, outflow tract obstruction, and these patients are at an extremely high risk of hemodynamic collapse. Ultimately, hypovolemia can worsen that obstruction, as well as mitral regurgitation, leading to hypotension and hemodynamic collapse. You want to avoid arrhythmias like atrial fibrillation, which can impair and reduce left ventricular filling and stroke volume. They're very preload dependent, so you want to maintain euvolemia, and you want to prevent increased contractility. So some of the medications that we typically use can really get you in trouble with patients in this situation. Just a picture. So this is how transesophageal echo can help guide management intraoperatively. So right here we're seeing left ventricular outflow tract obstruction, which can be a sign of increased risk for hemodynamic collapse. And right here we have an arterial tracing of pulsus bispherians, where you see these two systolic peaks that is seen during outflow tract obstruction as well. So these are just different monitoring tools that can be employed with the assistance of a cardiac anesthesiologist to help get this patient safely through surgery. For the next case, we have a 56-year-old male. He's a former smoker, and he arrives for hepatectomy following a metastatic lung cancer diagnosis. History includes severe pulmonary hypertension. His mean pulmonary artery pressure is 48 on right heart catheterization, and he also has severe right ventricular dysfunction. So these are some of the sickest patients to deal with, and some of the patients that give me stress as well, just because of that combination of severe pulmonary hypertension as well as right ventricular dysfunction. So management can be a little tricky. With severe pulmonary hypertension, you have a high risk of adverse events. It's an increased mortality and morbidity, and it's especially seen in patients undergoing non-cardiac surgery. And with chronic pulmonary hypertension, you most likely will see that hand in hand with right ventricular hypertrophy and right heart dysfunction. So the increased morbidity and mortality is mainly caused by right ventricular failure, arrhythmias, hypoxemia, and myocardial ischemia. So for these cases, advanced monitoring is really helpful just to glean more information. So including the use of a pulmonary artery catheter as well as TE can help dictate management and really give you an idea of whether or not you have to escalate support. So heart failure, that kind of goes on the continuum with severe pulmonary hypertension. The ultimate goal is to optimize volume status because you have a narrow window in doing so. You don't want to volume overload the patient leading to distension, or you don't want to underfill. So you want to use monitors to follow the trends and help guide care. With right ventricular dysfunction, you want to reduce the pulmonary vascular resistance. You want to correct hypercapnia, hypoxia, or acidemia. And this typically will require the need for a pulmonary artery catheter. For left ventricular dysfunction, the ultimate goal is afterflow reduction so that you promote the forward flow. And this advanced monitoring, pulmonary artery catheterization, transesophageal echo, can help dictate when you need more inotropic support, if you need assistance with a mechanical assist device. But ultimately, these patients don't tolerate systemic hypotension, so you want to avoid it at all costs. And with this advanced monitoring, that can help minimize the risk for failure. Pictured is a pen that one of my colleagues gives out to a lot of the trainees. It says, "Think about it, do it, respect the RV." So the RV is one of the most sensitive components of cardiac anesthesia. So that's definitely something we want to protect because once it starts failing, it's really hard to recover. For the next case, we have a 68-year-old male who's scheduled to undergo right upper lobectomy for lung carcinoma. His history is significant for angina, and coronary angiogram shows severe triple vessel disease with the right coronary artery totally occluded, and 80% stenosis of the left anterior descending artery and left circumflex artery. Ejection fraction is 25%, and coronary bypass is considered but is ruled out given the increased risk of tumor progression. So the decision is made to insert an intra-aortic balloon pump via femoral approach prior to surgery to provide myocardial support. So we're seeing more and more in the non-cardiac OR setting the use of mechanical assist devices. I know one of a later presentation is going to go over LVADs in non-cardiac surgery. So I'll just briefly talk about the use of intra-aortic balloon pumps. It is a temporary mechanical circulatory support device that's used in certain cases of cardiogenic shock. And sometimes we can actually use it as a bridge intraoperatively to get patients through the OR experience. So it uses counterpulsation to augment cardiac function. It inflates throughout diastole and deflates at the end of diastole prior to the next systolic ejection to help improve cardiac output by about 20 to 30%. It reduces afterload, and it also decreases myocardial oxygen demand. So in these cases, you want to maintain adequate mean arterial pressures and normal sinus rhythm. And most importantly, timing is everything. So you want to make sure that your arterial line tracing looks somewhat like this throughout the case so that we're actually getting the benefits and not causing any complications throughout the procedure. So just consulting quickly with a cardiac anesthesiologist, especially if this isn't something that you use all that often, can help optimize care. And lastly, we have a 56-year-old female with metastatic ovarian cancer who's undergoing an extensive debulking procedure. The patient acutely becomes hypotensive with a blood pressure of 78/49, pulse ox is 89%, and you notice a drop in end-tidal CO2. The patient is now on 100% FiO2, but there's persistent hypotension despite multiple vasopressor boluses and fluid resuscitation. You suspect an intraoperative pulmonary embolus. So cardiac anesthesiologists can be really helpful when employing rescue transesophageal echo. So this is used emergently to aid in diagnosing unexpected hemodynamic instability or cardiopulmonary arrest. And there are a couple indications. This is a rescue echo protocol that was compiled in 2019 that goes over a quick way to just evaluate and rule in or rule out certain pathologies in order to optimize management. But ultimately, the use of rescue echo can result in a prompt change in management. And you can also consider doing a rescue TTE with the same benefits. Changes in management include medication administration, fluid management, need for new or altered surgical procedures, or escalation of care. So do these patients ultimately go to the ICU versus somewhere else? So you're just gleaning more information in a more of an emergent situation. But common diagnoses include left ventricular dysfunction, so that can help tailor your care: right ventricular dysfunction, hypovolemia, pulmonary emboli, and myocardial infarction. So all throughout training and just as an anesthesiologist, we hear a lot that we are a consultant. So our main goals within our field are to safely and comfortably get patients through surgery. And that's increasingly becoming more and more difficult with these more complicated patients that present to our ORs on a daily basis. There's an increased prevalence for cardiac patients undergoing non-cardiac procedures. And cardiothoracic anesthesiologists have advanced training in managing these high-risk patients. So think of involving a cardiac anesthesiologist all throughout the perioperative period. So preoperative, while you're working up a patient, you can consult and just learn how to, or touch base on how to optimize patients prior to the operating room. In emergent situations, consulting a cardiac anesthesiologist may be helpful to assess disease severity. Doing a quick surface echo to rule in, rule out significant cardiac lesions can be really helpful in guiding management. Intraoperatively, we can provide considerations given specific cardiac pathologies and what our maintenance and induction goals are. And lastly, we can assist with placing and interpretive advanced invasive monitoring. So that includes difficult to place central venous access, pulmonary artery catheters, as well as performing perioperative transesophageal echoes. Thank you.
Thank you, Dr. Richardson, for giving that very thorough but yet concise and helpful overview of some of the patients that cause challenges for all of us and how we can work together as a team to really take great care of our patients. We are now going to transition to our second lecture, where Dr. Kristen Haller is going to be talking about perioperative pacemaker management and some of the future therapies that are actually becoming more and more mainstay. And they were, 4 or 5 years ago, they were just sort of the novel ideas, but they're things that we're seeing even more. Just as a quick introduction to Dr. Haller, she graduated from the Ohio University of Osteopathic Medicine. She trained at the Cleveland Clinic not only in anesthesiology, critical care, but also cardiothoracic anesthesia. And for the past few years, she has been down in the Phoenix, Arizona area working for Valley Anesthesiology Consults. As a cardiac anesthesiologist. She enjoys point-of-care ultrasound, echocardiography, and mechanical circulatory support devices, and also spending lots of time with her mini cats. And that's how she enjoys her days. So we'd like to just take a few moments to welcome Dr. Haller to be here, thanking her for being here with us today, and we'll listen to her lecture on pacemakers.
All right, well, thanks, Jen, for that introduction, and I only have 3, so there's not that many cats. But all right, thanks, guys. So I'm going to talk to you about this topic that I think we have all dealt with in the preoperative period, and sometimes leaves me even kind of scratching my head with, what do I need to do with this patient and their device? Do I need to modify anything for their surgery today? I have no disclosures. These are our learning objectives for the talk today. So why should we care about perioperative pacemaker management? An estimated 500,000 to 3 million folks in the U.S. have a pacemaker or an ICD. And with the prevalence of heart disease in an aging population, we're going to see more and more of these patients coming through our ORs. Over 70% of pacemakers and ICDs are implanted in patients over the age of 65, so we expect the number to continue to grow. And then as an aside, it's 10 p.m. Do you know where your cardiologist is to help you out with the management of this device? I usually don't. So what devices are we talking about? Cardiac implantable electronic devices, or CIEDs, is an umbrella term that covers permanent pacemakers, implantable cardioverter defibrillators, and cardiac resynchronization therapy devices, which we see in our heart failure population. Most of the information from this talk is coming from this practice advisory from 2020. So in some of the areas where we might not dive deeply enough, or you want to reference back, this is a great paper to go back to. So some basic CIED function and terminology. Pacemakers are typically devices placed for bradyarrhythmias, so patients with issues like sick sinus syndrome or complete AV block, who are going to be dependent on a pacemaker to provide that electrical impulse for conduction. Patients who are pacemaker dependent are patients with an underlying rhythm that would cause them to become symptomatic, or a non-perfusing rhythm, like the rhythms we were talking about. Some patients may just have pacemakers as a backup device, so if they're occasionally symptomatically bradycardic from a slow sinus rhythm, they may not be pacemaker dependent 100% of the time. ICDs are devices placed for primary or secondary prevention of cardiac arrest. So we're talking about your patients who either have had a malignant arrhythmia, and so they're placing this device so if they have that arrhythmia in the future, it can shock them out of it, or patients who qualify based on their risk of having a future event but just haven't had one yet. So typically those are heart failure patients with low EF, or people who are at risk of sudden cardiac death, like our HOCAM patient that Dr. Richardson had mentioned in her presentation. Cardiac resynchronization therapy is in heart failure patients who, when their ventricle dilates, they get a wide QRS, and so you want to pace the left ventricle along with the right ventricle to synchronize ventricular contraction, narrow their QRS complex, and hopefully alleviate some of their heart failure symptoms. So those are kind of the broad categories of devices we're going to consider when we go through the rest of this talk. Pacemakers have a standardized code as far as what their programming is, and so that's a 5-position code. The first position is what chamber is paced, so I always remember you're not going to put in a pacemaker and not pace something, so that's an easy way to remember that that first position is always which chamber is going to be paced. So you can either pace just the atrium if they have intact AV conduction, you can pace the atrium and the ventricle or just the ventricle, and so that's why we have D for both, dual, A for atrium and V for ventricle. The second position is what chamber is sensed. So, we have a lead in the ventricle, it's going to sense the ventricle, and then it's going to potentially pace the ventricle, or do you have a lead in both chambers? Third is what is that device going to do when it senses what that chamber is doing. So if we have an atrial and a ventricular lead, and we have an atrial impulse generated by the patient, the device is going to sense that atrial chamber depolarization. It's not going to pace the atrium, it's going to wait for a period of time. If the ventricle fires on its own because of the native AV conduction of the patient, it's going to inhibit the device, so it's not going to activate a ventricular pacing. And if after a period of delay, the ventricle hasn't gone off on its own, it's going to pace the ventricle, so you'll get AV or dual chamber pacing. The last two positions, 4 is rate modulation. So this is a component of some devices where either by temperature or impedance or respiratory rate, you can increase, the pacer will automatically increase its rate to increase cardiac output because it's sensing that the patient may be engaging in some more exertional activity and need a little bit of extra output. And then multi-site pacing most commonly refers to chronic cardiac resynchronization therapy that we mentioned before, and that's because you're going to have an atrial lead, a ventricular lead, and then you're going to have that left ventricular lead, typically through the coronary sinus, but we'll look through some other options to pace the left ventricle in synchrony with the right ventricle. So we talked through some of these. In red are kind of the common ones that you'll see. So DDDR means that they have an atrial lead, a ventricular lead, and they can both sense or pace both of the chambers. And then that R means they have the rate responsiveness function. DOO means they have both an atrial and a ventricular lead, so they're capable of pacing either the atrium or the ventricle or both if needed. The O means that we're not sensing anything. So this is what we consider an asynchronous mode, and that's what a lot of times we'll want to program patients to during surgery because of the potential for electrical interference that we'll talk about later. So we're going to talk through some aspects of the preoperative evaluation of these patients. And so this is where sometimes, depending on how much information you get when your patients come into your preoperative area, you might have to do a little bit of detective work. So first you want to identify that your patient has one of these devices, either through H&P or chest x-ray, or looking at the patient to see if they have any scars on their anterior chest wall. And then you want to dig into what type of device is this? Is this just a pacemaker alone? Is this just an ICD alone? Sometimes the patients are very helpful in this. I've yet to have a patient produce one of these cards for me that tells me exactly what device they have, but sometimes they are pretty knowledgeable and they can tell you, oh, I have a pacemaker because one time my heart was too slow and so they just needed a backup for me. And sometimes not so much, so we have to do a little bit more digging. And then you want to do some work at figuring out what the current device settings are so you can figure out what to do with the device intra-op. The good news is that we don't have to rely too much on our patients to figure out what the device is. So just from a simple chest x-ray, we can pretty much tell where the leads are going. So if you look at this little cartoon, and then we'll look at some real chest x-rays on the next slide, that first position is going to be where the right atrial lead sits in the right atrial appendage. Number 2 is the right ventricular lead going down to the apex. 3 is the lead that's going through the coronary sinus over to the left to pace the left ventricle in CRT therapy, and that takes that characteristic kind of squiggle. And then you may see patients who have epicardial leads placed. These might be patients who have previously had transvenous pacemakers placed, and they no longer have anatomy that supports getting across the coronary sinus for some reason or another. We also see these sometimes in our cardiac patients. Oftentimes they'll place temporary epicardial leads for us. So looking at these chest x-rays from right to left here, You can see in that first image, that's a dual chamber pacemaker. You just see the bright whiteness of the tips of each lead. So there's one in the right atrial position and one in the right ventricular position. The next picture across, you can tell the difference in the thickness of that lead. So when you see those bright white coils, you know it's an ICD, either with or without additional pacing leads. So we know that that patient has an ICD. The third picture, you're going to see it's a little bit harder to see the ICD coils. I think you can see the coil best on the right ventricular kind of lead position, but you can see easily that coronary sinus lead taking that sort of characteristic turn going over to the left side of the heart. And then last is a device we didn't talk about yet. That's a loop recorder. It has no leads. It's for patients who either have had Holters that didn't capture their arrhythmia or need longer term arrhythmia monitoring, maybe to identify their burden of atrial fibrillation. And so there's nothing that we need to do for these devices other than to just try to make sure that we're not passing a cautery directly over them. This is kind of a busy slide, but it's just to illustrate that there's a lot of ways we can tell specifically what the device is if needed, just by kind of the characteristics of the generator can. And so this is kind of an article you can reference if you're interested, but they all have kind of unique shapes and radiographic markers, so you can tell which company it's from if you need to. Then when I was looking up things for this talk, I kind of ran across this, and since AI has been a big topic lately, this is a pretty recent article from January where this team was looking at using an AI algorithm to determine what type of device was present, specifically just based on AI analyzing the chest x-ray. So, that really inspired me to just have ChatGPT write the rest of the lecture. So you guys can let me know if you thought the first half or the second half was better. This is just for your reference and to know that all of the manufacturers do have a 1-800 number. So if you have a question and my patient has a Medtronic pacemaker, is an MRI safe? What's going to happen to it if I put a magnet on it? You can call this number and they can direct you in the right path to find out. Text on this slide is really tiny, but this is just to illustrate what a device interrogation might look like. So what information is it going to give you? So some important things are, it's going to tell you what rhythm the patient's currently in and what the rhythm underlying the device is. So in this patient, they had a sinus rhythm underlying. It's going to tell you the remaining battery life on the device, which can be important if you're coming right down to the end of it. It's also going to tell you any events that have occurred, either atrial or ventricular arrhythmias since the last device interrogation. This is going to tell you some other information about that the device is functioning as it should. And then on the bottom, we had this device reprogrammed for surgery. So you can see programming changes made today, that second line underneath the bold line on the slide, that the ICD was programmed off and the pacer was turned to an asynchronous mode for the surgery. I just wanted to mention that it's sometimes helpful to know what's available at your own individual hospitals. I know it's been kind of a steep learning curve for me to find out who I can get into the preoperative period if I need a device interrogation. In our pre-op area at the main hospital I go to, we have a device little check thing for the main companies where the pre-op nurse can just put a wand on the patient. She can't reprogram the device, but that will wirelessly transmit to the rep even if they're not in-house, and they can give you a call back if there's anything wrong or if you have any questions. That's another way to get a hold of them other than going through that just generic number. So how recently for an elective surgery does the device need to have been interrogated? The good news is that Miller and the practice guidelines that I showed you are pretty much in line with this, that a pacemaker should have been interrogated within the last 12 months, and an ICD should have been interrogated typically within the last 6 months. For you to be sure that it's working appropriately. And the time course difference is mostly related to kind of the severity of what would happen if the patient lost the functionality of their device and that ICD, and maybe the resynchronization patients might be on the sicker side and so may benefit from a more recent check. So after having done our pre-op investigation, looking forward to going to the OR, what do we need to plan to do with these devices? So first we need to figure out, are we likely to encounter interference during the course of our case? If the answer is yes, and we're going to talk about how to figure out if the answer is yes in the next couple of slides, then we probably need to reprogram the pacemaker so that it's not affected by the interference, and especially suspend the ICD function if it's an ICD. And the main thing that we worry about is oversensing. Typically in our cases it's due to bovie. And so what oversensing looks like in a pacemaker is that the pacemaker interprets that electrical signal as the cardiac activity, and so it inhibits the device completely, effectively turning the device off and making the patient reliant on whatever their underlying native rhythm is, which sometimes, especially in a pacer-dependent patient, isn't going to work. And then what oversensing in an ICD looks like is the device will interpret that as a tachycardia and potentially deliver an unwanted shock to the patient. So this is a list of potential sources of electromagnetic interference. Like we mentioned, electrocautery is probably the one we most frequently encounter. That practice advisory goes really nicely in depth with the rest of these on the list. And I think if you're interested in what you need to do in each of these specific scenarios, that paper is the best way to look. Just for the interest of time, I'm not going to go through kind of all of them. This little graphic is basically illustrating that when you're using monopolar cautery, what you want to do is position the bovie return pad in a way that from the surgical site to the return pad, the current is not going to cross the device. So magnets, everybody's like, just put a magnet on it, it'll be fine, right? So what do the magnets do to these devices? It depends on the type of device, but in general, if you put a magnet on a pacemaker that is only a pacemaker, it's going to set it to an asynchronous mode at a rate that is determined by that device and that manufacturer. So a Medtronic device may revert to an asynchronous rate of 100. A different manufacturer may revert to an asynchronous rate of 85. And so it depends on what device you have. And that's where it's helpful maybe to contact the manufacturer if you think there may be issues in a patient where that rate may not be appropriate. Putting a magnet on an ICD will turn off the anti-tachycardia function of the device, but if the patient also has a pacer along with that ICD, it won't change the pacer to an asynchronous mode. So you're still going to have that potential for oversensing of the pacemaker that the patient has along with their ICD. So I mentioned that magnet rates might not be appropriate for all patients. So think of your aortic stenosis patient who's really well beta blocked, has a heart rate of 50 or 60. You put that magnet on, now their heart rate's 100. They might not tolerate that hemodynamically. And then the other thing with magnets, where the surgeons want you to just put a magnet on it, positioning is a big consideration. So unless you're supine and can easily tell that that magnet is positioned correctly over the device, if you're going lateral, prone, it might be harder to tell whether that magnet's going to stay in place throughout the case. And I will also mention that my previous experience was when you put a magnet over one of the ICDs, you'll get a little high-pitched tone for a brief period of time, and that lets you know that it was properly positioned over the device. And I had one recently from a manufacturer I wasn't that familiar with. I put it over the device. It made no tone, even though we moved it all over the patient. So I ended up calling one of my EP guys, and he said, oh yeah, that company doesn't make a tone. So be aware that it may be properly positioned without the tone, which I think is a little annoying because you don't know if it's in the right spot. But you typically will get a tone, but maybe not always, depending on the device. So this is kind of the crux of the talk. What do we do with the devices? It's a pretty easy flow chart to follow. So my patient has one of these devices. Are we going to be boving above the umbilicus? If not, the likelihood of interference is low, and so we don't necessarily have to do anything to the device. Just have a magnet in the room if you see interference. And this is just from the most recent edition of Miller. If we are going to be having bovie above the umbilicus and it's a pacemaker, then we ask, is the patient pacemaker dependent or not? We didn't mention it earlier, but if the patient can't tell you if they're pacemaker dependent or you don't have a recent device check and you can't tell, grabbing a 12-lead EKG in pre-op and seeing if every beat is paced. If it is, that's a good indication that the patient is probably pacemaker dependent. So if they are, you're going to want to put a magnet over it and that will turn it to an asynchronous mode. Or preferentially, and depending on your positioning, you may want to get a rep out to reprogram the device for you. If the patient's not pacemaker dependent, you can consider reprogramming it, but you don't necessarily need to, and you can just have a magnet available, again, depending on how easy it is to place the magnet during the case if you run into any issues. And then if the device is an ICD, you want to deactivate the ICD component if there's going to be bovie above the umbilicus. And then beyond that, like we talked about, if they also have pacemaker dependency, you're going to want to have that reprogrammed to an asynchronous mode because, like we talked about, the magnet is not going to change the response of a pacemaker that's paired with an ICD. So this algorithm is kind of targeting an elective case where maybe you have time to get a rep in, talk about reprogramming the device. If you don't have time, it's a very similar algorithm, but simplifies a little bit. So if you have to go in an emergency, you can't get a rep, and you have one of these devices, they mention right away you're going to want to measure in some way the pulsatility of the patient, which we typically do anyway, and that can either just be through your pulse ox waveform, or you can place an arterial line to monitor for any unanticipated interference. It's my practice that if you turn somebody's ICD off, I always put pads on them, just because if you do encounter a need to defibrillate them during the case, going under the drapes, putting them on, the current size of most of our patients and wherever the surgical site is, it can be kind of cumbersome. So I just always put them on if I turn their device off. And then, as mentioned, if you're not sure if they're dependent, get a 12 lead and see if you can figure that out. And it's the same exact management as the previous slide. So if they're pacemaker dependent, use a magnet. Tell your surgeon maybe don't bovie for 60 seconds at a time. But if they are and you've got all that bovie artifact, you're either going to have your arterial waveform or your pulse ox that tells you that the patient is actually generating a conducting beat underneath there. Same thing for the ICD. You want to put a magnet over it. Again, the magnet's not going to change the pacemaker to an asynchronous mode. So this is the instance where you really want to encourage the surgeon to use short bovie bursts. And that is about it on that. So if you want to program the device, make sure that if you have it done in pre-op, once the device is off, the patient's on continuous telemetry because you don't want to turn off their device, come back and get them and find them unresponsive. You want to make sure that there's temporary pacing and defibrillation equipment available. I don't usually have them put the pads on in pre-op. I usually wait and do that when we get back to the room, but just make sure that the nurses know that their device is off if they're going to be waiting in pre-op for a period of time before they come back to surgery. And then as far as intra-op monitoring, this one's pretty easy for us. So we're going to use all of our standard ASA monitors. We're going to use continuous EKG and pulse ox. And then again, we're going to use some way of continuously monitoring the pulse, either by pulse ox or arterial line. And I would say I have a low threshold to place an arterial line in patients who are, especially patients who are having an emergency surgery where you don't know how dependent they are on their device. Just gives you a little bit of a closer monitor for what their blood pressure is doing. Post-operatively, we're going to monitor them just like any other patient. Typically, again, if I've turned their device off, their ICD off, I leave the pads on and take them to PACU. That's just so the PACU nurses don't have to scramble if they have an issue in that period of time where they're waiting for the device rep to come back and reactivate their device. And then the device rep will do a post-op interrogation and make sure that there was no damage to the device during the course of the case. So that kind of in a nutshell is how you're going to go from preoperative to post-operative with a patient with a CIED. And so now we're going to shift gears a little bit, touch on some of the complications that you see with these devices, and we'll see that a lot of them have to do with infection risk and leads. So with the generator, you can have pocket infection, you can have erosion through the skin, you can have hematoma, and all of that can lead to the potential for infection. You can have thrombus formation on the leads, and if they have a PFO, that can potentially cause a stroke. Leads passing through the tricuspid valve can cause significant tricuspid regurgitation. Leads can fracture over time if there's a lot of motion in the leads, and either infection or lead fracture can all lead to the need to remove the leads. And if they've been in there a long time, passing through that subclavian vessel, sometimes they're really scarred in there, leading to potential for vascular injury when they're taken out. So it's kind of a big deal, and we can appreciate that most of the complications have to do with the intravascular leads, and that kind of gives us a clue for where some of the future directions of these devices are headed. So we're going to touch briefly on each of these devices that you may see kind of expanding in the patient population coming towards you. So first we're going to talk about the subcutaneous ICD. It eliminates those lead-related complications that we just mentioned, initially improved in 2012, but doesn't have long-term pacing. So if you have a patient who needs an ICD and a pacemaker, they're going to need something else. This is what it looks like. The generator is implanted kind of in the mid-axillary line on the left, and it has a single defibrillator lead that's tunneled across the anterior chest and then up along the lateral sternum. You can see with this, it does have a traditional magnet response, so if you put a magnet on it, it will disable the device. I almost always, if I have a chance, have them deprogram this device though, because getting a magnet to stay on the patient's side, you end up putting a bunch of that like really heavy chest tube tape and trying to get it to stick there, and it's just a pain. So typically I would recommend having these programmed off and then just turn them back on after the case. So that's pretty cool. Does it work? Studies say yes. Has a similar rate of first shock conversion as our traditional devices. So I think we're going to start seeing these more and more. This is just some of the literature that has to do with some of the initial studies of these. Next, we're going to talk about these leadless pacemaker systems. So there's two from a couple different companies. There's the Micro from Medtronic and the NanoStim. Out where I am, I have not seen a NanoStim, but they're doing quite a few of these micro pacemakers. What this is it's a little, just a couple centimeter device that's delivered through a catheter-based delivery system from the femoral vein. They go up there, it has these little anchoring feet. They stick in the apex of the right ventricle, and so that can provide pacing to the patient without the need for any leads. To note, the NanoStim does have a magnet response, so it will go asynchronous with a magnet. How you can tell you're over the device, I'm not entirely sure. I don't think you're probably going to hear any tone from inside the cardiac cavity. So, and I don't have any experience with trying to place a magnet on this device. The Micra doesn't have a magnet response at all, so you're going to need to have that device reprogrammed. So like we were talking about, the sub-Q ICD didn't have any pacing capability. So of course we can have these combo systems, and this is one of them. So you can have one of these leadless pacemaker seeds and a sub-Q ICD. So you've got your entire pacemaker and defibrillator without any transvenous leads. So that's kind of cool. The WISE CRT system is another novel system to alleviate the need for that coronary sinus lead. So what this is you have a traditional RV pacemaker or ICD, and then they put this little LV pacing seed in the left ventricle. This one's not approved in the US. Last I looked, this is currently approved in the UK, but may be coming towards us in the near future. So the benefit of this device is that when you put that coronary sinus catheter across to be your main form of resynchronization therapy, you're limited in where you can pace that left ventricle. With the seed, they can do some functional cardiac imaging, determine where potentially the best place to generate that LV pacing impulse is, and then stick that little seed in that area that would be most beneficial to the patient. And then lastly, this is something that we're starting to see in our practice, a new device for heart failure patients called the Barostim. And I thought their website was pretty interesting because I'm sure this is every cardiologist's motto, is outsmart the heart. And if you see something that looks like a traditional device, but the leads are tracking up to the neck, this is probably the device that you have. So it's a similar electrical impulse generator, but you're putting a lead up to the coronary sinus, to the baroreceptors. And so what that's doing is stimulating the baroreceptors, hopefully decreasing the sympathetic outflow to help those heart failure patients decrease their afterload. So kind of a new device, has some kind of interesting anesthetic implications when they're implanting the device, but we are starting to see some of our surgeons put these in. And that's all I have for you.
Well, thank you so much, Kristen, for that great overview of, I think, the things that we have to go look up every time we run into a new patient that has a pacemaker. So great to have a very concise overview of that. We're going to switch gears just a little bit for our next lecture that Dr. Katari is going to bring to us. So it's going to be about LVADs for non-cardiac surgical patients. And I think as a cardiac anesthesiologist, probably Kristen, Ria, and Perrin and I would all agree that this is one of the #1 consults that we receive. asking if we can come to the GI lab to help out with a patient with an LVAD. And there's a lot of things to consider for that, so we're going to let Dr. Katari talk us through those. Just a quick overview for those of you who did not hear Dr. Katari yesterday. He is currently a cardiac anesthesiologist at Stanford University. He went to the Rowan College of Osteopathic Medicine. He did his critical care, I apologize, he did his anesthesiology residency at Cleveland Clinic, and then did his cardiothoracic anesthesia at University of California, San Diego. So, Purin, we're very grateful you could be with us this morning and talk us through this subject.
Good morning, everyone, and thank you, Dr. Hargrave, for that kind introduction. Today we'll be talking about some perioperative considerations of patients with an LVAD presenting for non-cardiac surgery. So here are our learning objectives. We'll talk about some key perioperative concerns with patients with an LVAD, understanding their coagulation issues that these patients may present with. We'll discuss an intraoperative hypotension algorithm if you get into trouble. And then we'll compare different LVAD parameters and their perioperative implications. We'll discuss some of their settings and try to understand some of the vocabulary that exists around these devices. And then we'll discuss modifications to the ACLS algorithm in case that is needed in your LVAD patients. And the focus of this talk will be considered durable LVADs, so implantable devices directly into the heart that are permanently placed, either as destination therapy or a bridge to transplant. Non-durable devices such as Impellas or balloon pumps won't be discussed as they have different management. So non-cardiac surgery in LVAD patients. Almost in some studies, 1 in 3 patients will require non-cardiac surgery at some point after their LVAD implantation. The 2 largest retrospective studies noted that the most common non-cardiac surgeries included endoscopies, tracheostomies, and vascular access procedures. Surgery is generally indicated to address bleeding and its complications, as the most common surgeries being upper and lower endoscopies and cystoscopies. And surgery is generally indicated for these cases, and almost 40% of patients will have, with LVADs, will have GI bleeding at some point, and that's usually due to gastrointestinal angiodysplasia or creation of AVMs, and because they're on long-term anticoagulation and antiplatelet therapies. So here's the overview of the things that we'll discuss. Care locations, their standard preoperative assessment, functional capacity assessment, PACER and AICD concerns, the LVAD types, lab studies that may be relevant, current medications, and the special considerations for anticoagulation, and imaging studies that may be helpful. So where should these patients be taken care of? Care should be taking place at patients familiar with the LVAD therapy. They sometimes have management teams, and such as an LVAD kind of coordinating team that has coordinators, perfusionists, cardiologists, cardiac surgeons, and anesthesiologists. Though a patient coming in for emergency surgery, you may not have access to these teams and these team members, which is why this talk sort of exists to help you guide you through sort of some of those cases. The next question we should answer is whether these patients require a cardiac anesthesiologist every single time. In a 2018 study by Brown and their team demonstrated that there was actually no significant associations between the type of anesthesiologist, and they looked at the amount of fluid that was given, vasopressor use, and invasive monitoring placement. And there was also no difference in outcomes regardless of the anesthesia provider type. So based on the results of this study, patients with an LVAD can be managed by cardiac or non-cardiac anesthesiologists and given their similar outcomes. The caveat is those non-cardiac anesthesiologists have to feel familiar with the management of these devices. Ideally, if the patient can be admitted preoperatively and evaluated and optimized, that would be ideal. But let the nature of the surgery, whether it's emergency or not, obviously guide whether they need to go direct to the operating room as well. So, of course, we won't belabor a standard preoperative assessment, but especially important is your NPO status and an airway exam. Functional capacity is an easy indicator to evaluate how stable these patients are, if they can be compensated versus decompensated, and easy ways to evaluate that would be peripheral edema or pulmonary edema on a chest x-ray and a presence of shortness of breath or dyspnea on exertion. A thorough review in systems and a physical exam can go a long way. Next, you sit down in front of your computer and you look through their chart, and here are some important things to look for. What medications are they on? Are they in the ICU on inotropes? Are they taking diuretics every day? What's their anticoagulation status? And are they on any antihypertensives? Next, you want to try to evaluate their LVAD type and their controller and to see if they have any power elevations, low flows, the status of the battery, and driveline function. And we'll go through all of those in turn. You want to check their relevant lab studies such as renal function, hepatic function, hematological status, and try to have an active type and screen. And we won't belabor AICD or pacemakers because Dr. Holler did a great job covering that, but evaluating that is important as well. So as a review, all patients who require LVADs have to be anticoagulated. We'll discuss the HeartMate 3 device, which is sort of the most common device that we see in the last few years. The standard therapy for that HeartMate 3 device would be having a goal INR of 2 to 3 and using warfarin, and then also antiplatelet therapy with aspirin between 81 to 315 milligrams. The discussion with your surgeon about whether that warfarin needs to be reversed is paramount. Some surgeries can be performed in the setting of a therapeutic INR, although some may require discontinuation. Generally, if you have an elective case, you can bridge the warfarin with heparin and let the warfarin wear off and stop your heparin 6 hours prior to surgery. In emergency situations, you may require reversal, which we'll talk about on the next slide. Generally, aspirin can be continued in the perioperative period, except for specific surgeries such as ophthalmological, neurological, or spine surgeries. So if you and your surgeon decide that the warfarin needs to be reversed, the literature does not support emergent reversal with vitamin K, FFP, or 4-factor PCCs because of the increased risk for pump thrombosis, unless there's a life-threatening GI bleed, for example. So the ideal situation would be letting that warfarin naturally wear off and bridging with heparin. Another common coagulation issue that we see with these patients are type 2A acquired von Willebrand's disease. This is actually caused by the shear stress of the impeller, and this actually starts right away, a few minutes after the initiation of the device. There is sort of a molecular mechanism that includes proteolysis and other sort of non-relevant, clinically relevant things, but knowing that this device prevents the collagen and platelets from binding together at the site of injury. Despite almost the universal onset of acquired von Willebrand's disease, not all patients have clinical manifestations of it, and sometimes that sort of shows that there's a multifactorial problem with these patients. But interestingly enough, if the patients have their LVAD device removed, for example, for heart transplantation, this acquired von Willebrand's disease goes away. I thought that was pretty interesting. PACER and AICD concerns, if you have to evaluate if there's going to be electromagnetic interference, remind them not to put the dispersion pad in the way, and we'll sort of skip through the rest of these details as covered by Dr. Holler. The newer devices may not be affected by electromagnetic interference, but older LVAD devices can be. So if you have an opportunity to perform your own echocardia exam using POCUS or having your echocardia lab grab some images for you, here are the things that are really relevant for you to focus on. Try to have them assess for inflow cannula patency and position, and look for velocity less than 1.5 meters per second there. You want to look for valvular function, especially if there's a degree of aortic insufficiency. If the valve opens at all, sometimes during the surgeries they actually sew the aortic valve closed, and evaluate the degree of tricuspid regurgitation. Look for aortic outflow graft patency and RV dimensions and function. The evaluation of the RV is sort of the most critical because it allows you to strike a balance between under-resuscitation and over-resuscitation. Patients with an LVAD require adequate LV preload for the pump to function appropriately, and otherwise you can have consequences such as low flow, low power, and suction events, which we'll talk about. So you've prepared the patient for the operating room, you're ready to take them down. How do you transport them? Well, transporting with the VAD specialist would be very helpful as they can inform you issues and interpret their monitors, their LVAD monitor. As an anesthesiologist, you'll be otherwise occupied with monitoring vitals, hemodynamics, airway management, etc. So it's really helpful to have a VAD specialist help transport with you, if possible. So you move on to the intraoperative phase, you move into the operating room, and you want to note some of your baseline LVAD parameters, and these we'll talk about in detail. First, there's a pump speed measured in RPMs, There's pump flow in liters per minute, pump power in watts, and the pulsatility index for heart rate patients. This is also known as flow pulsatility in HVAD patients. So this is a chart of the baseline parameters. I'm not sure anyone, even cardiac anesthesiologists, commit this to memory, so this can easily be found online. We'll focus on the HeartMate 3, as I mentioned. So their average pump speed is 5,000 to 6,000 RPMs, pump flow is 4 to 6 liters per minute, power is 4.5 to 6.5 watts, and pulsatility index between 3.5 and 5.5. You start placing your monitors and you notice your pulse oximetry doesn't work. We always attempt to use it, but since these patients may not be pulsatile, the pulse ox may not work. Alternate choices would include using cerebral oximetry, although there are definitely flaws and limitations to that, and serial arterial blood gases. Placing an arterial line to draw those and trend those helps you monitor oxygenation throughout the case. Next, we talk about intraoperative blood pressure monitoring. In some patients, there will be enough native pulsatile flow, so you can use an oscillometric, non-invasive blood pressure monitor, but generally not. And this pulsatility may go away after you induce anesthesia. Alternatively, you can use a manual sphygmomanometer and auscultate, or use a Doppler. But for relatively longer cases, that can be cumbersome, and arterial line would be best. Generally, I've never regretted placing an arterial line in these patients. Mathis and their team found that over 55% of patients with an LVAD who undergo non-cardiac surgery have blood pressure monitoring gaps of more than 20 minutes, which is sort of not defendable as it's not standard of practice for per our ASA monitors. Your target map in these patients usually is 70 to 80, and elevated maps greater than 90 can actually reduce LVAD flows, promote pump stasis, and can have been reported to cause cerebrovascular accidents. IV access. Of course, as usual, it's dependent on the surgery and patient factors, but it's reasonable to have one large bore peripheral access prior to induction in case a volume load is needed in the peri-induction period. You can consider post-induction central venous access if you're considering the requirement of vasopressor use. Invasive monitoring, as we discussed, arterial line is generally recommended for longer procedures, but notably respiraphasic monitoring such as systolic pressure variation and pulse pressure variation are generally unreliable in these patients. A PA catheter is reasonable to place if the patient has known RV dysfunction or pulmonary hypertension. A TEE, if you're comfortable and able to use that, can also be helpful for fluid management and RV monitoring. So, induction considerations. As usual, the agents you use to induce the patient generally don't matter, but you have to follow some induction parameters, which will be helpful for maintaining a steady hemodynamic state. For preload, we look at trying to preserve that preload to the pump. You can give gentle IV fluid hydration, especially if they're having a small bowel obstruction, for example, with a lot of nausea and vomiting, but be careful of trying to overload that RV. You want to generally maintain your LV and RV contractility. You're trying to avoid reducing the afterload significantly, maintain the patient's sort of normal baseline heart rate and maintain them in normal sinus rhythm. And you want to avoid conditions that can increase your pulmonary vascular resistance, such as hypoxia, hypercarbia, acidosis, and overventilation during your bag mask ventilation period. The increased volumes can prevent preload from coming to the heart. Sometimes you may have read in some older literature about patients who have LVADs requiring a rapid sequence induction. That is important for patients who have flow devices such as an axial flow device that has the LVAD below the diaphragm in the abdomen region. Generally, newer pumps such as HVADs and HeartMates 3s are all intrathoracic, so you don't necessarily need to do a rapid sequence unless they have other indications that may require one. So rapid sequence only required for HeartMate 2 devices or axial flow devices that have something in the abdomen. Is it helpful to have a depth of anesthesia monitor? ABIS or SedLine is helpful generally because these patients don't respond hemodynamically in a normal way to light anesthesia, so they may not get tachycardic or hypertensive if they're light, so having this device may be a good supplement if it's available to you. Can you provide regional anesthesia to these patients? Generally, if they're getting an orthopedic surgery on a limb, peripheral nerve blocks have been used safely in these patients who are on anticoagulation. Regarding neuraxial anesthesia, generally considering the risk of their anticoagulation status, positioning issues, infection risk, it's not used very frequently, but if you're interested in placing one, just make sure you follow your ASRA guidelines for the anticoagulation. So how do you evaluate volume status in LVAD patients? As usual, you can examine the surgical field, drapes, suction canisters, laps, and sponges. You can also trend the urine output. You can trend your CVP if you have one, and use TTE or TEE. And you can also look at some of your VAD parameters. If you're having low flow alarms, that can also indicate some hyperperfusion and a low volume state. If you do have the access and skill to perform a TTE, that can help you with volume status because you can look at the IVC measurements, the LV size, RV size, and if there's any septal shifts. But if you don't have access to the chest, it may be difficult to perform this, of course. Pulsatility. So we kind of talked about this earlier, that patients may have some intrinsic remaining ventricular function, but a loss of pulsatility is generally pretty common in these patients. But then if there is residual pulsatility that shows that there is some native heart function, without it, the LVAD is doing more of the work of the cardiac output. We'll talk about pulsatility index, which actually measures the extent of pulsatile flow from the LVAD itself. And it depends on a few factors, such as LV preload, contractility, the rhythm and rate, and the fixed speed of the device settings. If you're getting a high pulsatility index, that means you could have adequate preload or improved intrinsic LV systolic function. But if you have a low pulsatility index, that means your LV may be unloaded or having poor contractility, your VAD is functioning harder, or you have an increased systemic vascular resistance. So this is sort of the key algorithm for this talk. It helps you determine exactly what path you should take if you're facing hypotension in the operating room. So first, this article defines hypotension as a MAP less than 60 for these devices. And the first thing you look for is the LVAD flows. If you have high LVAD flows, you can consider that you have a vasodilatory issue. If the patient has a fever, you can assume that they have sepsis and you want to start broad spectrum antibiotics, look for source control, and initiate vasopressors. If the patient doesn't have a fever, you can look at if they're having vasodilatory medications. You can try to hold their vasodilators or try to change your anesthetic technique to cause less vasodilation. And you can also, again, initiate vasopressors. The low LVAD flows pathway is slightly more complex, but relatively straightforward when you think about it in subcategories. First, if you have low flows, you want to consider if you're hypovolemic or if you have cardiac or obstructive shock. First, you look at the JVP, which is an easy indicator of their volume status. If their JVP is elevated, you can attempt to perform an echocardiogram and place a PA catheter because you generally are concerned about the right ventricle. If you do find right ventricular dysfunction with a high CVP, and you do, for example, find a low wedge pressure, that is true intrinsic RV dysfunction, and you can begin inotropes. Otherwise, you can look for tamponade, pulmonary embolus, or pneumothorax. But if you don't have RV dysfunction on the echo, you could have inadequate loading by your LVAD, and then you can increase your pump speed and assess your cannula position. In general, we try not to make any changes to the settings of an LVAD of a patient who's come in with stable settings. Generally, it's us as anesthesiologists that are causing the LVAD to not work well, either by volume status or vasodilatory status. So we generally try not to change the speeds or any LVAD parameters intraoperatively because they're already optimized for that patient. If you find that you have a low JVP, and we're going to go all the way to the left side of the screen now, and you have decreased pulsatility or you're having a suction event, a suction event is sort of defined as, I like to use the analogy of a vacuum cleaner sucking a rug into it. So if you have a suction event, your left ventricle is too empty, and there's nothing for the vacuum cleaner to pull into its device. So then it starts pulling on the rug, and it stops the device and obstructs the device. So if you're having a suction event, it's generally due to a decrease in your LV volume status. So if you're concerned about that, you can check for your hematocrit level. If you have low hematocrit, then of course you can transfuse. If you have an adequate hematocrit, you can consider you're just hypovolemic and bolus crystalloid or colloid. So there's your sort of overview of dealing with hypotension when you're having these LVAD devices intraoperatively. So you decide you want to start vasopressor therapy. How should you go about it? Which ones should you choose? So you want to remember that VADs are what we call afterload sensitive. Maintaining an afterload is important because it allows for a gradient to exist across the device and promotes forward flow. Of course, anesthesia decreases your afterload, so low-dose vasopressor therapy is generally indicated and can be initiated early. Norepinephrine is generally a good choice, or vasopressin if you're concerned about the pulmonary vascular resistance, although all of the vasopressors available to you are generally okay to use. If you decide you need inotropic therapy because you have low pulsatility, you want to rule out hypovolemia first, and then you could begin your inotropy therapy. As we discussed, if you're concerned about RV function, you can also consider using inodilators and inotropes as needed, or you can use afterload pulmonary vascular resistance afterload reducers if they're available to you. We'll discuss sort of each of the LVAD parameters in a little more detail now. The first we'll discuss is the pump flow. As we mentioned earlier, there's average flow is 4 to 6 liters per minute. And the flow is actually dependent on fixed speed settings and the pressure gradient across the pump. So it's actually estimated, it's a calculated function using a patented algorithm. So it doesn't necessarily represent a true cardiac output as you would have if you had a PA catheter in, for example. So the estimation of pump flows from power can be a problem when there's pump thrombosis. So if you have a thrombus in the pump, the machine works harder and it increases its power to pump against that resistance or that thrombus. That way, when the algorithm calculates it, it's thinking that there's actually more flow going through, and you can erroneously calculate higher pump flows. So just because you have higher flows doesn't mean necessarily you don't have a problem. It doesn't correlate to cardiac output on a 1-to-1 ratio. We'll move on to pump speed. Average pump speed 5,000 to 6,000 RPMs, and that speed, as I mentioned earlier, is generally fixed with ramp testing preoperatively to optimize LV unloading and allows for periodic LV ejection. Periodic LV ejection is ideal because it decreases the risk of aortic insufficiency, aortic stenosis, and decreases the risk for thrombus forming in the aortic root or the coronary arteries. If you're having a low fixed speed alarm, you can be concerned about pump thrombosis or stasis within the pump. If you're having a high fixed speed alarm, you can get hemolysis, you can get excessive LV unloading and suction events, you can get loss of pulsatility, aortic insufficiency, and RV dysfunction as well. The next parameter is pump power. The pump power represents the energy required to run an impeller, and it's measured linearly directly by the device. There's a linear relationship between pump flows and pump power. So increased power consumption can be due to increased preload and higher speed settings, but a reduction in power can be due to cannula obstruction via thrombosis or low speeds or low preload. If you find an abrupt decrease in your power without an increase in your flows or speeds, you could be concerned about a device malfunction or pump thrombosis. You get through the surgery, you solve your hypotension problems, you sort of understand the general principles of all the parameters, and now you're ready to emerge. Of course, you want to follow your standard extubation practices, but monitor for abrupt changes in your preload, afterload, and contractility, because those can have exaggerated hemodynamic effects more than they usually could. And don't forget to reprogram your pacer or ICD if you need to. And the last thing we'll sort of talk about is ACLS in your LVAD patients. Ventricular tachyarrhythmias are actually really common due to these patients' advanced cardiomyopathy. They could also have re-entry circuits from LV inflow, infarction scars, and myocardial irritation from suction events. This can affect your RV filling, your systolic performance, decrease your LV preload, and cause low flows and hemodynamic instability. So some people say the rhythm doesn't matter when you have an LVAD flow, but if you don't have enough rhythm to give you enough preload, this can cause downstream consequences. ACLS generally is a challenging thing to perform in these patients because you don't have a detectable pulse, so you're not sure when you have achieved return of spontaneous circulation, or ROSC. So you're also dealing with two devices. You're dealing with, of course, the patient. You also need to interrogate the VAD as well because it could be a VAD issue. So first of all, we want to clear up the misconception that you can't do CPR in LVAD patients. You absolutely can do CPR if they are unresponsive and if they don't have a hum, meaning you don't hear the LVAD functioning. First, of course, call for help and check for that LVAD function, and then place your defibrillator pads and check for a shockable rhythm and shock as appropriate. that can sort of follow your regular ACLS pathway in giving appropriate pharmacological support and then continue with your CPR and the rest of the protocol. Initially, you may have heard that CPR was not recommended because there was an increased risk for dislodgement of the grafts or the device, but most of us agree that the benefits of beginning circulation using CPR outweighs the risks of pump dislodgement. If you have postoperative care concerns, they generally can be recovered in PACU if the surgery was uncomplicated and does not require ICU admission for other reasons. But you want to make sure that wherever the patient's destination is, the bedside nurses are comfortable taking care of those types of devices and those types of patients. From there, the patient can be admitted to your general post-surgical floor, again, if the team allows, if the staffing allows. But regardless of location, the competence of the nursing team is very, very important. I'll conclude there, and here are some of the references that I used. Thank you for your attention. I look forward to your questions.
Well, thank you very much, Perrin, for that wonderful overview. We now have some time for questions and answers from the panel. There are microphones at the in front of the room. Please come forward if you'd like to ask our panel anything. I did have just a couple of questions that I've been jotting down as I've been listening here today. One thing I wanted to ask the panel is with respect to patients with cardiac dysfunction or disease coming for non-cardiac surgery. I was thinking of like an aortic stenosis patient. How critical do you think it is to sort of have a cardiac anesthesiologist on standby? And maybe I'll set up the scenario because we will induce these patients. Oftentimes it goes quite smoothly without any issues. We prepare for bypass for 90 minutes to an hour or so under general anesthetic, and we see train tracks. So what are some of the factors that might be important as you're thinking about, I have an aortic stenosis patient coming in for a general procedure. When do you really need to reach out for that extra hand?
I guess I'll start, then pass it down. I think, and I think Rhea mentioned this as well. Most of our general partners in my group are pretty comfortable taking care of fairly severe valvular lesions, and I think some of it has to do with how well compensated the patient is. So that would sort of be my threshold. I typically won't give anybody any grief for consulting for a pretty decompensated patient. If they're well compensated and relatively active and can move about and do their ADLs at home, most likely the induction is going to go smooth. It's also helpful to have their recent information. So how critical is their stenosis? Is it moderate, or is it, critical, and they're having some urgent procedure that they need before they can address the valve? So that's sort of my take on that.
Yeah, just to echo, I mean, aortic stenosis you see more and more often in the non-cardiac operating rooms. I think our presence is really important, especially when these patients are hemodynamically unstable, or you're anticipating large volume shifts, large fluctuations in their blood pressures, which can cause a lot of complications. So ultimately, it's up to you. If you're really concerned, I think there should be a low threshold just to seek advice and consultation.
One last thing I'd like to add is certain caveats to the aortic stenosis patient. If you're concerned that they have a low ejection fraction, or if there's concern for low flow, low gradient aortic stenosis, or if there's aortic stenosis in the setting of some other valvular lesions, I think those are patients that are pretty reasonable to consult cardiac anesthesia on. The one thing that I sort of tell my residents when we're dealing with sort of a more straightforward aortic stenosis patient is that as long as you keep the hemodynamic goals in mind, my phenylephrine doesn't work any differently than a general anesthesiologist phenylephrine. So you just have to be comfortable in initiating it early and when you're trying to take care of these patients.
Excellent. You have a question?
Yeah, it kind of follows the same vein. So if you're in a setting, for example, community hospitals, there is no consultant, or if you're in a surgery center or whatever you're doing. So really for me, sometimes it's, do we do this case or not? It's not who can I consult, it's do I cancel this or not? And so sometimes it's easy if you try to come to me with an LVAD, say, thank you, that was so easy. No, we're not doing this here. But oftentimes it's not. And so when you're looking, and Dr. Richardson, you mentioned that revised cardiac index score, like if you're looking at these patients and yeah, they have maybe 3, because we see them, or maybe even 4, when do you start deciding, that's better for me at Cleveland Clinic or Mayo or, I don't know, your level 1 center, Abbott Northwest, wherever? So there's no one for me to consult. So it's moving on or not. So where do you draw that line?
Yeah, so that's a big gray area, and you have to take into account your comfort zone, the surgeon's comfort zone as well. So that would require a team talk to see where the patient is best suited for surgery. I think you also have to consider what emergency devices you have. Like if you do run into a complication, what services or medications or devices are available as well. So if you have a good backup plan, then I think you can, go forward with the case, just knowing that the risks are there and having a good, honest discussion with your whole team. If someone on the team doesn't feel comfortable taking care of that patient, then that would be a good time to transfer care to a better suited location.
And I just wanted to say I have been requested cardiac anesthesia to the ambulatory surgery center, and I would say that's almost never indicated. So if there's some question about whether you need a cardiac anesthesiologist in a freestanding ambulatory center, I pretty much always decline those patients.
I will just say that I think it's a great question, and that's the hard question because there are no guidelines. It's not like NPO guidelines that say 2 hours, 4 hours, 6 hours. It's there's some ambiguity there associated with it. But I do think patient conditioning is critical in this discussion. We all see moderate aortic stenosis patients that can barely move, and we see moderate aortic stenosis patients who walk 5 miles a day. And I would say that would be the complexity of the surgical case, how much you would expect hemodynamic alterations, whether it be fluid shifts, blood pressure, etc. Um, and then how well the patients are doing. What's their functional capacity? And I think those would be 2 factors. Those are the things that I'm looking at when I'm taking care of these individuals and sort of judging how involved I think the case will be. So hopefully that's of some help, but I wish we could give you the 2, 4, 6-hour guidelines like we do for NPOs. Dale, you have a question.
Yeah, thanks to all the presenters. I think it's obviously a very pertinent and complex topic, so I think you handled it really well, and I appreciate the information shared. For those of our colleagues that don't have access to a cardiac anesthesiologist, as a colleague, I think there's there needs to be an emphasis placed on how we triage these patients. So at your respective institutions, is there any system or workflow in place to ensure that these patients are going to the right location before we get the LVAD patient at an ASC for an elective hernia?
I can comment on our sort of system that exists for elective cases. So generally, it's up to the surgeons to recognize that they may need a preoperative anesthesia visit. Not every patient getting surgery at our institution is scheduled at a pre-op anesthesia clinic. So all the surgeons know it exists, and it's sort of up to them when they're reviewing the patient, or in reality, most likely they're a mid-level provider that's doing the H&P to review and recommend a pre-anesthesia consult. On the day of surgery, if something slips through the cracks and these patients are scheduled, um, there's a couple of options that we offer. We can actually transport them within our system and reschedule them on the same day at one of our higher care locations, or sometimes we're able to send a flex person out who's more comfortable taking care of those patients. So we do have that flexibility in the system, and I recognize that they may not be done at every single institution, but I think there should be a low threshold to recommend them to be cared for at the preoperative anesthesia clinic, because then they can place them in the right care location. Otherwise, it's important to recognize that it's painful to sometimes cancel and reschedule these cases in an appropriate location, but it's better than dealing with a severe complication in a remote location.
Yeah, so at the Cleveland Clinic, I think we have a pretty similar infrastructure. So very extensive preoperative evaluation is done to see where these patients belong, whether it's in the general um, operating rooms versus the cardiac operating rooms. But sometimes we do have some um, cases in the general operating rooms that do require more involved care regarding cardiac care. So very often we get consulted just a phone call away and say, hey, we have this really sick patient. We're not comfortable dealing or taking care of them in our operating rooms. Do you mind if we transfer them to the cardiothoracic anesthesia operating rooms just for more involved care? I know for our LVAD patients, I know there's essentially a flow sheet that's been employed to dictate which patients are done with general anesthesia versus cardiac anesthesia, and a lot of that has to do with how severe their comorbidities are, most importantly, including right ventricular dysfunction, and how high of a risk for needing more involved care these patients are. So ultimately, it's up to a provider's comfort, and just calling and saying, "Hey, we need an extra hand," and those patients will get transferred over to our setting.
Do you have any thoughts, Kristen? Just because I know that your practice is slightly different than some of us who may have more
Yeah.
resources for preoperative assessment.
Right. So I'm in a large private practice, so I'm typically the victim of inadequate pre-op workup. So we have a couple of guidelines for our general partners that are sort of hard stops. I think we say EF less than 20 is a green light to call one of us. Any of the mechanical circulatory support devices, either VADs or temporary devices like ECMO or Impellas, we always get consulted on. So those are kind of our hard stops, and obviously within the group, there's a lot of phone calls that happen if somebody just has a quick question they want to run by one of the cardiac providers.
We have a question.
Yeah, I have a question about pulmonary hypertension. It seems like a few times a year we'll get someone that comes to the operating room for either an elective or sometimes even an urgent surgery. And you'll look back through their chart and they have an echocardiogram done for whatever reason, and they'll have a diagnosis based on the echo of severe or maybe even moderate to severe pulmonary hypertension, sometimes in isolation, sometimes with other issues going on. And they see a cardiologist and nothing's ever mentioned about it. It seems like it's this thing that's almost like an incidental finding. And so there's no like what happens when I get this is I get a little confused because I'm like, okay, what should we be looking for in terms of optimization for somebody with pulmonary hypertension? Because it doesn't seem like there's really any treatment that these patients are on. So is there anything that we should be kind of looking for to make sure they're ready for surgery? Because even when I talk to our cardiologists, I don't know if this is just to our institution or if this is more global, they just don't seem to think it's a very big deal. So I don't know if I'm making a big deal about nothing when I reach out to them. And then my second question with that is when you have a patient like this, kind of what, if you guys wouldn't mind just kind of telling me what your setup is for that case and what your go-to meds are to have ready to go, for a patient with that diagnosis.
Sure. So I guess I'll start. I think, like we keep kind of mentioning, the better compensated the patient is, the less likely you're going to encounter some serious hemodynamic collapse, even if their pulmonary hypertension is on the moderate range. So if they can get up, move around, they don't say I'm short of breath or lightheaded or anything like that, or you don't see concurrent RV dysfunction on their pre-op echo, my threshold of concern is less, even if their right ventricular systolic pressure is like 50 or 60. You certainly see patients who have very severe pulmonary hypertension, and then your index of concern goes up, and then you want to think about ways to minimize increasing even further that pulmonary vascular resistance with whatever anesthetic technique you choose. So those are some of the things that Perrin talked about in his LVAD lecture. They apply to normal patients without LVADs too. So adequate depth of anesthesia, avoid hypoxia, acidosis. How urgent is the surgery? Do you have time to have cardiology see them? Do they need a right heart cath? Those sorts of things are the things that I think about. And then just, final note is that you may want to choose a pressor that, again, is not going to be deleterious to their pulmonary vascular resistance. So typically vasopressin is the go-to for that.
Yeah, it sounds like in your example, you've had patients that have known pulmonary hypertension, they've seen cardiology, and they're not making a big deal about it, that may be a good sign because that indicates that they're well compensated. I always look for, the warning signs, like, are they decompensated? What's their functional capacity, like Kristen said? Are they on any medications to minimize that pulmonary hypertension? So any pulmonary vasodilators, because that would kind of make me a little more concerned. Just examining the patient when you see them. Can they lie flat? Or do they look short of breath or really fatigued? Some of those physical findings can help you out as well. But when in doubt, I would just err on the side of caution and, you know, prepare for like a severe pulmonary hypertension and right ventricular dysfunction because it's better to over prepare than under in these situations because they are so tenuous. So typically, um, you can pre-oxygenate the patient with the nasal cannula, keep them in an upright position just to maximize um, some of their respiratory functions. An arterial line is always helpful so that you can optimize right ventricular function through maintaining adequate afterload. Um, on induction, use a cardiostable approach for induction, so maybe etomidate. Um, and then once you're asleep, central venous access with a pulmonary artery catheter can help, so you can kind of trend some of those PA pressures throughout the case to see how you can optimize settings. Most importantly, like your vent settings, minimizing acidemia and things that can exacerbate or worsen that pulmonary hypertension.
And to sort of address your second part of your question a little bit more, one, if they are on pulmonary vasodilators, you can expect systemic hypotension, especially after the induction of anesthesia. So some of these patients are the ones I start pre-induction vasopressin infusions, or even an inotrope to help support if the patient has RV dysfunction. And something I also emphasize is being sort of critically aware of your airway management strategy. These patients generally may not tolerate this hypoxia. They might not have the sort of several minute wait time that you can have for airway management. So these are the patients where I open the oral airway right away, have it ready. I don't try to struggle very much trying to establish bag mask ventilation. I just use the oral airway, establish your airway quickly. If they're a borderline challenging airway, have whatever equipment or support you might need to intubate them quickly so you don't have several minutes of more hypoxia or and hypercarbia building up in these patients. So I think, as my colleagues mentioned, preparedness is key. Having your drips programmed in line, having bolus medications ready, and having airway equipment and a backup airway plan quickly available is really important. We get asked a lot to provide pulmonary care for pulmonary hypertension patients who are undergoing what are normally considered MAC procedures, so like endoscopies, colposcopies, or like GYN procedures that are generally done with sedation. And those patients, some of them may tolerate having a sedation case with maybe high flow nasal cannula or other sort of advanced maneuvers. But generally, I haven't regretted putting an endotracheal tube in those patients just because there's so much to worry about, and the last thing I want to worry about is trying to oxygenate them and ventilate them appropriately. So having a lower threshold to convert to general anesthesia for what is normally considered a MAC procedure is also reasonable.
Yeah, I think you bring a great point, and actually, I was going to diverge just a little bit from some of the discussion here. I take care of in my vascular patient population a fair amount of, let's say, moderate to severe pulmonary hypertension, some more probably on the moderate with maybe some moderate RV dysfunction. And the reality with those patients is that I've often found that the full induction process, and maybe they're coming just for a case that needs sedation, right? Monitoring anesthesia care. Sometimes I think we can be our own worst enemies when we induce positive pressure ventilation in a patient that is compensated, even with some RV dysfunction and pulmonary hypertension on their own. So I will actually attempt and sometimes just use an LMA with a very minimal amount of positive pressure support, maintaining my oxygenation, being sure that we don't become hypercapnic, and and those patients will be okay. And I can let others speak to how they would prefer ventilation settings on those individuals. But just a little bit of sort of going back to hemodynamic management of pulmonary hypertension. If patients become hypotensive, be afraid of RV failure and have that a little bit more as your priority than just a decrease in your SVR. So I always have an inotrope very nearby. A small amount of epi may be very helpful just to administer to get that RV being able to compensate. And then and then perfusion pressure. So Kristen mentioned vasopressin. That's a great option to raise your coronary perfusion pressures in those patients who are so dependent on a higher coronary perfusion pressure to the right ventricle to maintain function. So I'll ask others, anyone else want to comment on ventilatory settings?
Yeah, I mean, I would agree with the LMA, use. I think that when you are doing a kind of a MAC or maybe a deep MAC case in these patients, your end tidal monitoring isn't always terribly accurate. So having something that can at least give you a better surrogate like an LMA can be helpful too in avoiding that hypercapnia.
Yeah, so for bigger cases, I think using other monitors to help drive your ventilatory settings can be helpful. So, for example, if you have central venous pressure, you can look at how your vent settings are affecting your preload, if there are effects in that. If you have an arterial line, you can do serial ABGs to see what your oxygenation, your CO2 status is. If there's acidemia, so that you can titrate your minute ventilation appropriately to optimize some of those parameters and minimize the effects of increasing pulmonary hypertension.
And in the patients with true severe pulmonary hypertension, it may be worth a discussion with your surgeon whether a 15-minute open API is going to be better than subjecting that patient to pneumoperitoneum. They may not tolerate it. And then again, this is a patient population where you may be thinking of putting a swan in for something that would otherwise be considered a minimal case, depending on their function.
One last comment on the vent settings themselves. I think just remember to overventilating them can help. That can cause decreased preload. So keeping your tidal volumes at sort of on the lower end of the spectrum that the patient needs is important, and marginally hyperventilating them to keep that end tidal CO2 a little lower than you might normally would in some other patients can also be helpful to help protect that RV just a little bit more.
One question that I had as I was listening to this, and it's been a fundamental question for me for the last few years, is how do we balance the need for patients to have surgical services, yet realize there are social determinants of inequalities in healthcare. So let me give you a perfect example. My family lives in a small town. We have a small hospital. It's a good hospital, but they have some limited resources. They're probably 2 hours from what I would consider like a really level one tertiary care center. If someone from my family has an LVAD, or if someone from my family has, let's say, moderate aortic stenosis or moderate mitral stenosis, and they need a relatively small procedure, it is a major ordeal to have to transport, potentially hotel rooms, etc., everything that's involved. So just curious the panel's thoughts on how can we help provide, where's the line? What care can patients receive at maybe smaller community facilities versus always being said you need to go to the top level or and realize that takes a toll on patients and may actually discourage them from having their knee scopes or having dental procedures or something like that, a simple surgical solution.
It's a great question. I think that we consider a lot about. We don't consider often enough patient factors in these decisions, and I think the best thing we can do is become more and more comfortable taking care of these patients, regardless of wherever their sites are. So, coming to conferences like this and learning about different ways to manage these patients, having sort of a mindset of continuous improvement can allow you to feel comfortable taking care of these patients in these settings. That way you don't necessarily need to transfer them out. So I think the responsibility falls on us as anesthesiologists to be as prepared as we can. That way we can make the care for our patients as best we can without having to subject them to different burdens.
Yeah, just to echo that, I mean, as anesthesia providers, I mean, we are a team. I know, for my resident class, we have a chat that's still going on, and we consult each other about different tough cases that we may have. So, for example, if I have a question about regional anesthesia, which I don't do too much of, I can ask someone all the way in Arizona about it, and they can give me feedback. Like Dr. Kothari was saying, his phenylephrine works the same as a general anesthesiologist phenylephrine. So sometimes a quick phone call can go a long way just to better elucidate a plan for induction, for maintenance, and most importantly, for complications that arise, to see if these procedures can be done safely in some of these smaller environments. So reaching out to friends within the anesthesia community can go a long way.
And I think the only thing I would add to that is, open lines of communication with your surgical colleagues. I think sometimes there's this area where they don't understand why we get so worked up about some of these things. Or, they may be declining patients because they don't want to deal with their anesthesia team because they know, oh man, last time I had this patient, they wanted them transferred, and they may not really understand the nuances of why that happened. So if you can open lines of communication with them and encourage them to reach out to you early, especially in the cases of elective cases like a knee scope or something, you may be able to guide them in what tests would help you best care for that patient on the day of surgery, and prevent that patient from needing to go to necessarily a higher level of care.
Were there any further questions for our panel?
So in that case, if I'm going to use a magnet, I'll still put pads on because how long that device takes to cycle back on may feel like a long time once you take that magnet off if the device doesn't fire. So for myself, intraoperatively, I do put pads on those patients. If I take the magnet off myself before going off to recovery room, sometimes I will take the pads off because they're not likely to need them in PACU because, like you said, the device should turn itself back on. Yeah, and in the event you didn't change the programming at all, you just put a magnet on and off, my level of concern would be how close the surgical site was to the device if you thought there was the potential or significant potential for the device to have had some damage. So if you're talking about an abdominal case and I put a magnet on, I don't typically require the device to be reinterrogated in the PACU setting or anything before I send the patient to the floor.
Well, any other further questions? Well, then let's give our panel a great round of applause for their excellent presentation of this.